Hello, good evening. You're all very welcome to this evening's GP webinar. It's the first in our GP webinar series for 2022. My name is Tamara Nolan and I'm the Director of Communications and Advocacy with St. Patrick's Mental Health Services, and I'll be moderating this evening's webinar. So the theme this evening focuses on psychological formulation and addiction. And joining us this evening are Dr. Violet Johnstone, who's Senior Counselling Psychologist, and Dr. Aideen O'Neill, who's a clinical psychologist with St. Patrick's Mental Health Services. So both Dr. Johnstone and Dr. O'Neill will be discussing addiction from a psychological perspective, as well as exploring emerging psychological theories related to addiction. Tonight's webinar is also going to look at the Temple Formulation Group here in St. Patrick's, which is a psychology group program for individuals who currently or historically have experience with addiction or substance misuse or abuse. Following these presentations, we're going to have a very short Q&A, we hope, if we have enough time, with our two speakers. And you can submit questions throughout the webinar just using the Q&A function at the bottom of your screen. So we'll try to get through a couple at the end if we have time. And just to let you know, our ICGP CPD certificates will automatically be sent within the next 4 weeks to any GP who's registered and who is attending live this evening. So we'll get started, and I'll invite Dr. Johnstone and Dr. O'Neill to unmute and switch on their cameras and take it away.
Thanks so much, Tamara. I'm just going to share my screen here. So hopefully everyone can see that. So just to get us started, just start with defining addiction. So the DSM differentiates between substance use disorders and gambling disorder, which is the only non-substance related disorder currently in the DSM. And there are 11 possible criterion for a substance use disorder that include some things that you'll probably be familiar with, like difficulty or inability to stop using the substance, life interfering and negative consequences, or tolerance, which just essentially means needing to take more of the substance to get the same high, and withdrawal. And so just to talk a little bit about the emergence of the brain disease model of addiction, Dr. Benjamin Rush was an American physician and politician, and Dr. Thomas Trotter was a Scottish physician. And both of them began to detail descriptions of addiction as disease in the late 18th century. And not too long after that, Alcoholics Anonymous was formed in Ohio in the United States in 1935. So the emergence of the disease model and the widespread of AA both provided an alternative way of understanding and treating addiction. And this was really important because up until this point, addiction was highly stigmatized, and it was often viewed as a moral failing or a lack of character, which we know today is not at all the case. And unfortunately, a lot of that stigma still exists today, but hopefully is reducing all of the time. So just to kind of introduce the biopsychosocial model, and we'll be talking a lot more about each one of these areas as we go throughout the presentation this evening. But so far, research points to substance misuse and abuse as being complex, like most mental health difficulties. Our early life experiences may impact how we interact with substances. Our genetics may impact how we interact with substances. Difficulties regulating our nervous system may lead us to seek out substances, and we'll go into more detail about that. And our communities, environment, and the supports that we have might influence in how we interact with substances. And you'll see there at the very bottom, I just have listed Rat Park. So I just thought I would mention this really quickly. So I believe it was around the 1930s or 40s, they did this experiment where they put a rat in a cage with 2 bottles of water. One contained just plain water and one contained water laced with either heroin or cocaine. And the rats, every time this experiment was replicated, or almost every single time, the rat would drink the cocaine or heroin laced water until the rat overdosed. But in the 1970s, a researcher was looking at this experiment and thought, hold on a minute, we're putting these rats in cages where they don't have other rats who they could form social bonds with or connections. They don't have toys, stimulation, nourishing food. So he built Rat Park, which was essentially paradise for rats. And there was lots of other rats who they could make friends, social bonds, have sex, and they could play and have lots of stimulation and run around. And what was fascinating was that none of the rats ever overdosed on the heroin or cocaine-laced water. And not only did they not overdose, but they didn't use the drugs compulsively. And in fact, they used them pretty infrequently. So.
Thanks, Violet. So Violet mentioned there, I suppose, the three kind of parts that we use to understand addiction, so the biological, the psychological, and the social. And I suppose to expand a little bit more on the biological piece, so Gabor Mate, who we'll talk a lot more about as the presentation goes on, and he's done a lot of research recently around addiction, and he talks about the three dominant brain systems in all addiction. So the opioid attachment reward system, the dopamine-based incentive motivation apparatus, and the self-regulation areas of the prefrontal cortex. And he talks about how all of these three brain areas are finely tuned by the environment and the experiences that people have in their lives. And to various degrees in all people who struggle with addiction, these systems are not functioning properly in some way. And there is a broad consensus, I suppose, as to the role of various neurotransmitter pathways in addiction. I suppose the problem with this is the precise causative alleles or groups of alleles in the genes of the particular neurotransmitter pathways involved in alcoholism. They're still not kind of fully understood. There's still not really consensus around the exact kind of mechanisms that are happening there. But I guess we do know that those neurotransmitter pathways tend to be involved in some way. So kind of mentioning Gabor Mate again, so he'll come up, as I said, a lot during this presentation. And so he's a Hungarian-Canadian physician, and he has written and spoke extensively about addiction. And he speaks a lot about the central role that he believes trauma has in people who struggle with addiction. And he feels that for many people, it's at the root of addiction. So he would say that, I suppose, as far as we know, about 66% of people who will struggle with addiction will have experienced some sort of trauma in their lives. And I suppose what that means clinically is that, you know, kind of thinking about trauma and treating trauma should help to kind of treat addiction as well. And it's important to understand that trauma is a subjective experience. So I suppose a lot of people will have different understandings of what trauma means, or the word trauma might have different meanings for different people. But I suppose when we understand what trauma is, we think about kind of any experience that overwhelms our systems to such an extent that we find it really, really hard to kind of feel safe again, and our brain finds it really, really hard to process what has happened. And I suppose in terms of how Gabor Mate would kind of explain the nature of the relationship between trauma and addiction, he talks about how early developmental trauma and exposure to stressors produce numerous neurobiological abnormalities, including changes in neural circuit function, which may manifest in dependence or substance abuse. And a review of the literature that he conducted in 2012 demonstrated that the stress response mechanism is involved in addiction. So he talks about kind of abandonment, neglect, or abuse, whether this is emotional, physical, or sexual, can alter the physical stress mechanisms, and the child, or indeed the adult, can become more reactive to stress throughout their life. And substance abuse or dependence is related to the stress response, and he would understand it in many ways as an attempt to self-soothe. And I suppose if we think about what this means clinically, and what myself and Violet would notice in patients that we meet with, a lot of our addiction patients who we meet when they kind of initially come off their substances in hospital, and they're kind of going through just that kind of early withdrawal, and we find that a lot of them are struggling with active PTSD symptoms and really struggling to manage the distress associated with that, and struggling with things like flashbacks. And I suppose if we think then about what we need when we've had trauma, or we've been traumatized in some way, we need things like soothing, connection, safety. And it's really tricky for people who struggle with addiction, because oftentimes It's the exact opposite of that they get. So they might get a lot of kind of, punishment or kind of abandonment, or kind of ostracized a little bit from their families or from society. And so that's an important piece to kind of keep in mind going forward.
So we mentioned the biological and social contributors, and research strongly indicates that there might be genetic predisposition towards substance abuse, as Aideen was saying, but it can be really difficult to pick out what is learned behavior and what is genetically passed down. So a child might grow up seeing a parent, a grandparent, an auntie, an uncle use or abuse substances, which might have an impact on how early they initially interact with substances, or how likely they are to kind of use the substances. And then a child in whose family there is substance misuse or abuse is unlikely to be getting all of their psychological and emotional needs met. So it's really hard to kind of know where the nature and the nurture end and begin. And as usual, they're always complex and dynamic, and they interplay with one another quite a lot. And I think Aideen kind of touched on this, but it is important, I think, when we're talking about trauma and emotional needs, to understand that often we think about trauma like things that happen to someone. So abuse, or sexual abuse, physical violence, but it can also be very, very traumatic what we don't get. So if we don't get that kind of very consistent, attuned, soothing, caregiving from our caregivers, if we don't get our emotional needs met, this can also be traumatic. Obviously, only if it's chronically and over time. And there are some medications that help with withdrawal and detox and cravings, such as Librium, Suboxone, and naltrexone. But addiction is treated with social and psychological methods, particularly once the initial detox phase is over. A lot of what happens then is geared towards those social and psychological treatments. So Alcoholics Anonymous, Narcotics Anonymous, Smart Recovery, addiction counseling, and psychotherapy. And Aideen mentioned a little bit there before about Gabor Mate and, kind of talking about the nervous system and dysregulation. So we wanted to just very briefly talk to you about polyvagal theory, which Aideen and I bring in a lot into our understanding of addiction in our work. So she's going to talk to you more so about it, but I'm just going to introduce this first part. So polyvagal theory is really based on the vagus nerve, which many of you are GPs, so you might be very familiar. Vagus is Latin for wandering, and that's because this nerve wanders all throughout the body. It starts in the cerebellum here, the base of your brain. It's connected to your throat and your face and your heart and your lungs and all your major organs. So it really wanders all throughout all of the really, really important bits. And it's kind of one of its core jobs is really informing your nervous system about how safe you feel in the world.
Yeah, so polyvagal theory, as Violet mentioned, is a really, I suppose we found a really accessible way of explaining to patients what happens within our body and within our systems when we're exposed to trauma and stress. And it might help them to understand a little bit how they feel within their own body. And I guess when we think about polyvagal theory, we often kind of explain to clients that, we have this kind of inner scanning device almost that, so we're wired for survival, and our vagus nerve and our autonomic nervous system, one of its big functions, I suppose, is to help us to survive. And so it's in ways kind of always scanning for danger. So kind of scanning for both danger, cues of danger, and cues of safety. And how we explain this to clients is that if our system is not picking up on, kind of cues of danger and, the environment is safe and our old kind of survival brain isn't activated and frightened that something is going to happen to us, we should be in this top part of the ladder here, our ventral vagal state. So, when we're in ventral, we feel safe, we feel connected, we feel present, kind of at ease. The kind of top thinking, logic, reason part of our brain is working really well, getting plenty of oxygenated blood. So, we're able to kind of logic and reason and problem solve, and there's a general sense of kind of openness and ease. So a place that we'd all like to be quite a lot of the time, but I guess our system will pick up on cues of danger, and that's pretty normal kind of throughout the day, so kind of different stressors. And when our system does pick up on these things, and this is kind of, you know, we describe to patients this is automatic, and the system is always on for all of us, we'll drop down to our sympathetic nervous system, or our fight or flight system. And I'm sure a lot of you will know a lot about this already. So our fight or flight system, our sympathetic nervous system, is kind of our mobilized threat system, and it's the first place that we'll go once our system kind of picks up on danger. So our heart rate increases, and we might feel kind of lots of muscle tension, and our temperature goes up, and our breathing, the pace of our breathing increases. And the general sense that kind of people give of being in sympathetic is everything is overwhelming. I'm feeling really anxious or irritated. The world is feeling kind of really dangerous and chaotic and unfriendly. So it's a really, and not a pleasant place to be, but I guess we'll all get there to some degree throughout the day in response to different stressors. Now, ideally, what would happen is early on in our lives, we'll have developed skills to kind of access safety and soothing, and to get back to ventral once once we've dropped into sympathetic, and this will usually need to happen, well, no, it would always need to happen as kind of co-regulation initially, so kind of a parent soothing us. And but for a lot of people, especially that we work with, they won't have gotten those needs met, as Violet kind of has spoken about, or because of trauma or lots of ongoing stress in their lives, they've not been able to get back up to ventral, to safety, and we can't stay in our sympathetic system for forever, and it would take a lot of energy out of our system. So eventually what would happen is we'll drop down to our dorsal vagal system, or kind of our freeze shutdown system, as we often kind of refer to it when we're explaining this to clients. And the universal feeling of being in dorsal, so everything kind of slows down, and it's our oldest survival system, and really we shouldn't be getting there unless our life was kind of in immediate danger. But again, for a lot of our clients, because they've spent so much time in sympathetic, or find it so difficult to access ventral, they will be getting to their dorsal, their shutdown systems maybe quite a bit. So the feeling of being dorsal, that people describe kind of a numb feeling, they feel kind of collapsed and really, really shut down. So, if somebody's in dorsal and you ask them how they're feeling, they might say, I'm not really feeling anything. I feel numb, I feel empty, I feel quite hopeless. And I suppose what we find that clients really like about this model is that everybody can relate at some stage or another to being in each of the three places, and it just helps them to kind of get a sense of, actually, I'm not the only person who feels like this, and actually a lot of us can feel like this at different times. So then how do we bring polyvagal theory into kind of understanding addiction? So important to say initially that polyvagal theory and its relationship to addiction does still require much research. So we can't really kind of support these claims with much evidence at the moment, but many psychologists are beginning to talk about addiction as an attempt to regulate our nervous systems. And if we go back to what Gabor Mate had said about essentially addiction being an attempt to self-soothe, if we're not able to access our top part of our system, our ventral vagal, our kind of calm state, we're going to be spending lots of time in our threat system, either our kind of mobilized fight or flight system, or that shutdown, that dorsal system. And it's really painful to be there. And I suppose if we can't do what we need to do, which is soothe and connect and get to ventral, a lot of people will go to numbing. So kind of we're stuck in threat, but we're at that point kind of trying to numb the distress associated with being in either our sympathetic system, so feeling that high anxiety, high stress, or that kind of dorsal shutdown, empty feeling. And where people tend to spend time in their systems, and maybe for some people feel quite stuck in their system, that tends to impact maybe the types of substances that they will go to. So if we think about kind of being in our sympathetic, our fight or flight system, people will often go to substances that are kind of down regulating and calming. Whereas if we're spending lots of time in dorsal, we would find that a lot of clients will talk about going to kind of stimulants, so maybe cocaine or kind of other stimulant drugs to help them kind of upregulate. So again, just going back to the evidence base for polyvagal theory in general, So recently, a lot of the research around trauma and working with people who've experienced trauma is beginning to talk about body-based therapies and the importance of using a bottom-up approach when we're working with people with trauma. And what this means is at a brain level, for people who've experienced a lot of trauma, because their systems, again, find it really hard to get into that safe, connected space where they're thinking really logically and clearly, we find that we actually need to work almost subcortically, kind of really on soothing and kind of biological skills to kind of downregulate before we're able to work with these clients at a more kind of cortical cognitive level. So these approaches teach the biology of trauma responses and the practice of emotion regulation through biologically based skills. So neuroscience theory does support somatic awareness models, and these therapies do have strong neurophysiologic underpinnings. However, research on these therapies is limited at the moment. Polyvagal theory incorporates a lot of elements from these body-based therapies, and many of these models would reference polyvagal therapy in their psychoeducational parts. And Stephen Porges is a big name in polyvagal theory, and Deb Dana, and they have written a book on how polyvagal theory can be applied clinically and how these three states can kind of help patients to get a better understanding of an otherwise quite complex model, and how kind of looking at cues of safety is a really important part of kind of treatment going forward.
So just kind of pulling together some of what Aideen and I have been talking about so far and kind of looking at a psychological understanding. I suppose Aideen and I would kind of understand it, and the psychological view would be that all humans seek to move away from pain and go towards reward. So that's how we're wired. That's part of survival. We feel pain as a signal to move away from something or to attend to something, and we naturally move towards reward and towards what feels good. And our brains are very wired for more short-term survival. So we're kind of better at thinking about how to survive in the moment versus some of that long-term survival, particularly when we're in pain or a very difficult situation, or when our threat system is activated. And trauma, attachment disruption, so kind of not getting that consistent soothing and our emotional needs met, and all those things that we need in childhood and adolescence and even all the way into adulthood. And our nervous system being dysregulated produce a lot of pain in the individual. So as Aideen said, we can't stay in that sympathetic place or that very shut down, empty pain place. So we will try to move away from that in whatever way we can. We will try to move away from suffering. That's just what it is to be a human. And I suppose it's very unconscious and specific to each individual. What our brain learns will help us move away from pain and towards reward. So again, it's not as simple as, sometimes I'll hear someone that we're working with that's struggling with an addiction say, well, this other person went through a tough time too, but they aren't an alcoholic or something like this. But it's much more complex and nuanced than that. If we go through difficult times in childhood or growing up, how many supportive resources do we have? What's our own level of sensitivity, emotional sensitivity, level of kind of external things that would help boost resilience? How early are we exposed to substances? What is our genetics in terms of kind of substance abuse, addiction? So all of these things, it's very, very complex, and no one wakes up one day and says, I want to be an alcoholic or I want to be addicted to something. There are really, really valid reasons why that happens. And so feeling shame, we know is very negatively correlated with substance misuse and abuse, with sobriety. Sorry, it's positively correlated with the abuse. But shame does not help. So I know Aideen and I, both in our work with people that struggle with addiction, would aim to really decrease shame and instead to increase self-understanding, non-judgmental curiosity, and helping people begin to understand themselves and maybe what they need, which we'll talk a little bit more about here. So this slide is basically just saying that there is good research to demonstrate that treatment can increase the chances of people maintaining sobriety with substance use disorders, and particularly over self-directed change efforts. So it's better if they do have therapy of some kind. And it appears that there's not a single best treatment for alcohol or other substance use disorders. And there is evidence that the effectiveness of several different treatments, and 3 of those are adapted CBT, motivational interviewing, and acceptance and commitment therapy. And as Aideen mentioned before, a lot of other treatments are coming in now in terms of sensory motor treatments, polyvagal based treatments, all of these, but those still need more research.
Thanks, Violet. So when we look at and try to understand maybe the mechanisms of change behind these various treatments for addiction, studies tend to kind of come back to the common factors and the common mechanisms of change behind and that kind of underlie the effectiveness of all psychotherapeutic approaches. So these would be the therapeutic alliance. So this is kind of the relationship between therapist and client. This is formed really early, and it's formed through kind of collaborative formulation with the client, gaining mutual understanding between therapist and client, and that, I suppose, feeling of safety and warmth that the client gets when they're in that relationship. And again, kind of thinking back to some of what we've covered already around kind of the importance of soothing and safety within our system, you can see why this part is really important. Expectations are really important. So a lot of, I suppose, patients will come into therapy with certain beliefs about and certain stories about why they are struggling in the way that they are. And these tend to be often quite short and quite self-critical and quite maladaptive. So a big part of, I suppose, developing expectations and the importance of that is that we need to kind of help clients to develop an understanding that I suppose helps them to believe that there's something they can do to overcome their difficulties or to cope with their difficulties. So rather than kind of coming in thinking, well, you know, I struggle in this way because there's something wrong with me, or I'm terrible, or which is often what we hear, you know, I can never change. For those expectations to change, to actually, you know, well, now I can understand a little bit more why I do struggle in the way that I do. It makes a little bit more sense to me, and I feel that there are things I can do to kind of make some positive change. So kind of giving clients a sense of agency within that. And there are, of course, kind of specific ingredients, so kind of a specific treatment or specific skills that would be really helpful for a particular client and that would be tailored to their particular needs. And that would kind of be really based on the first two. So within the context of a warm and trusting therapeutic relationship and the understanding that they've gained as well, kind of through formulation. So I think when we're thinking about kind of addiction treatment, it's really important to just look at the research and the figures around comorbidity of addiction and other mental health difficulties. So alcohol and drug use disorders occur in conjunction with many other psychological disorders. So among people diagnosed with an alcohol use disorder, 37% will meet criteria for another Axis 1 disorder. And the most common diagnoses and the most common comorbid difficulties that we will see with people would be mood and anxiety disorders, often with comorbid PTSD being particularly elevated, which again makes sense in the context of what we've been speaking about. Axis 2 disorders would also be really common, with rates reported up to almost 33%.
So just further kind of supporting that point there, bipolar and major depression disorder are hugely comorbid. So the lifetime prevalence rate of any bipolar disorder and any substance use disorder is 47.3%, so nearly half. And for bipolar 1 disorder and any substance use disorder, just over 60%. So that's huge. And then for major depression, there's a lifetime rate of 40.3% for any alcohol use disorder and 17.2% for any drug use disorder. And then for major depression and alcohol dependence, the lifetime rate is 21%. So the clinical implications for a high level of comorbidity are that clients with co-occurring disorders tend to have more severe course of illness, more severe health and social consequences, and more difficulty in their treatment, and then worse treatment outcomes. And much of the evidence would point to treatments for both substance use disorder and other psychiatric disorders being effective in reducing substance use and improving behavioral, familial, and psychosocial outcomes. And evidence further suggests that these outcomes might be improved when treatment modalities are offered in combination with an integrated treatment plan that simultaneously addresses substance abuse and psychiatric problems. I suppose we're bringing this in because Aideen and I would see it as so important, in our clinical work, that a person has, the support of their doctor, potentially psychiatry, potentially social work, that they have NA or AA or those social supports, and that they're also getting the psychological and therapeutic treatment. Really important, because as we know, addiction doesn't exist in isolation, and this is part of treating the whole person and all the things that might be contributing to the substance misuse or abuse. And I suppose then that kind of, for that final point there, I suppose the public health perspective is really important. And I know a lot of us are out there working at the individual level and doing our best, but a lot of this is systemic and how it's treated. And I suppose that begins even up with the government and the political level, and kind of comes down how much funding and how much support that we have for people with addiction. But it really is so important that we have a multi-treatment approach. So I suppose this kind of leads on to the catch-22 of addiction, which is that a lot of people need sobriety to engage in therapy in a meaningful way. So it's really hard to engage in therapy if you're high or if you're drunk. And at the same time, a lot of people need therapy to maintain their sobriety. So particularly, Aideen and I would see this in early recovery. This can be a really, really difficult place for people who have been using substances to sort of numb or suppress difficult emotions because of trauma, because of difficulty with making connections, because of unmet kind of needs that have kind of continued throughout life, and really low self-esteem. All of those things, cause a lot of pain, and people might be numbing them or suppressing them with their substance. So when we take away the substance, suddenly, oftentimes people are flooded with a lot of distressing emotions, distressing thoughts, and their sense of, often there's still a lot of shame and all of that happening, and they don't yet have the trauma processed. They don't yet have the tools for regulating emotions or self-soothing. So it's just a really, really tricky place. I think in AA they kind of call this white knuckling it, where you're kind of trying to, you're just kind of gritting your teeth and trying to get through, which isn't sustainable. So again, that's why it's so important, if we can, that we kind of have this multi-approach where we're helping people gently to begin to process trauma, or even just in the beginning of early addiction or early sobriety, early addiction recovery, even that we're offering kind of some supportive therapy, and then that they're getting kind of social needs met as well.
So in terms of kind of how we are, kind of myself and Violet are trying to address all of these things, and the importance, I suppose, of trying to help people kind of work on both their kind of addiction piece and their mental health difficulties, kind of ideally at the same time. We draw a lot on the power, threat, meaning framework, which is a framework. It's relatively new. It was brought in by Violet Johnstone, who's a psychologist over in the UK, and a number of other kind of psychological kind of figures in the UK. So this framework would put forward the position that mental health difficulties should be understood using a multifactorial and contextual approach, and again kind of drawing heavily on that biopsychosocial model. And kind of that idea that a lot of these different factors in an individual's life should be taken into account in any explanatory model. And in terms of what this really means in practice, myself and Violet would often think of that idea of, rather than kind of asking somebody what is wrong with you, which can be the I suppose, which can be the urge oftentimes when we're trying to get an understanding, we like to kind of try and ask what has happened to you, and to kind of get a greater understanding of a person's story. And I guess the benefit of this is that the more kind of complex and the more of a deeper understanding we can get around kind of what's happened to a person and their story and their life experiences. This gives us a lot more information around kind of intervention, what could help, how to get out of these kind of tricky patterns and cycles that are happening. Whereas when the explanation around somebody's difficulties is quite I suppose doesn't take all of these factors into account, it can make it a little bit more difficult to to think of, or I suppose to understand how to intervene in what's happening for the person. And then kind of clinically, how we've tried to bring this into practice is we've developed a novel Temple Formulation Group. So Temple is our kind of dual diagnosis ward in the hospital. So this is a 14-week program that is geared towards individuals who have struggled with addiction and or substance misuse and abuse. The group is transdiagnostic and it's not specifically focused on addiction. So everybody who would attend the group will have had a past experience of addiction, or maybe kind of they're in early recovery. But the group is more geared towards that question of kind of what has happened to me, understanding my story, developing kind of a greater understanding of my formulation. So we don't focus kind of exclusively on addiction, or we actually have 1 week where we talk a lot about addiction, but that's out of the 14 weeks. So it's much broader than kind of focusing exclusively on the addiction piece. The group provides connection, normalization, and collaborative formulating. And again, if we think of things like the role of shame and trauma in addiction, connection is really important. Normalizing is really important. Group members will often report having more clarity around what they need going forward, a lot more hope. So again, kind of thinking about changing expectations and kind of shifting narratives to maybe more hopeful narratives. And again, reduce shame and insight into their behaviors and difficulties. I suppose, what are the benefits of formulating in a group? So again, just going back to that kind of normalizing and de-shaming piece. So a lot of people who will come to our group and kind of myself and Violet's experience has been that people often feel really isolated. They can have narratives around kind of, I'm the only one who struggles in this way. So to be in a group of people who struggle in similar ways can be really containing and normalizing for people. And we've seen kind of over a number of cycles now within the group that that can really facilitate kind of opening up and kind of talking about things that people really need to have the space to talk about. It allows for activation of triggers and coping strategies, which can then be explored in real time. So I suppose this is the benefit of formulating together in a group. And kind of a benefit that we wouldn't necessarily get in one-to-one. So if we might understand that, say, for example, somebody finds kind of conflict really triggering, or, they find it really difficult to be around other people, well, they're in a group of other people, and oftentimes the group reflects what can happen outside of the group for people. And it allows us that opportunity to kind of check in around, are you triggered at the moment, what's going on, and to help them kind of formulate and understand what's happening in that really safe space. So providing safe and supportive environment to explore and become aware of painful truths. And there's great learning from one another in the group also. So there's a lot of learning around kind of my own story and kind of my life and how my experiences have impacted on me. But there's often a lot of learning around kind of other people as well, and kind of noticing how other people's stories might be relevant to their own. And also, I suppose, quite a practical benefit of formulating in a group for us is that it allows us to help more people. So we kind of catch more clients at once, which is always good.
So as Aideen mentioned there, on our group, we focus on understanding the story and kind of understanding their own story and moving from a place of what's wrong with me to understanding what happened to me. Because oftentimes what's going wrong has to do with how someone has learned to cope and manage really difficult situations or unmet needs. So our group's about retelling their story, and not necessarily just retelling it to us or to the other group members, but retelling it to themselves. For all of us, our kind of story of self how we think about ourselves and who we are and our ideas about ourselves start when we're really young. And because in childhood, just developmentally, we're narcissistic, not in a bad way. We don't have perspective yet, or we kind of understand things that happen around us as happening because of us. So if we have had if we've had trauma, or if we've had unmet needs, or if there's been just difficulties in our families, oftentimes people will internalize that as something is bad about me, or I'm not enough, or I'm not lovable, or I'm worthless. So the group really gives people a chance to begin to kind of see maybe these child beliefs from their adult self, and kind of with the information that Aideen and I provide, from the psychological perspective about what we need and how, what we need in childhood, adolescence, young adulthood, and in our adulthood as humans, and how our tricky brains work. This can begin to help people to really understand themselves differently, and to begin to understand what needs went unmet that potentially they are still going unmet, and how they can relate to themselves differently, and maybe begin to kind of reduce the shame, maybe begin to approach themselves with more patience, more curiosity, more wisdom, even strength and firmness. We talk about how compassion can be very firm, but it's from a place of patience and kindness. So towards the end of the group, we encourage our service users to reflect on how their stories changed over the duration of the group. And usually what we hear is narratives that were initially full of self-criticism and shame and hopelessness have moved to ones of self-compassion, deeper understanding, and hope for the future, which is so important, because Aideen said oftentimes people come in quite hopeless. So we thought it'd be nice to include a couple little quotes here. So some feedback from service users who've completed the formulation group. 12-week group was transformative. It has really changed me for the better. I'm more positive and optimistic, more patient with myself, and understanding of myself and others. And the journey was extremely emotional and very difficult, but on reflection, it was worth it, because I'm now very hopeful for the future. So this is just a little graph about where people tend to go next after they've done our group. So a majority go on and do individual therapy. And then those 4 in the middle are other groups that St. Pat's offers. So the compassion focused therapy group, we have listed LTD, but that's actually our dialectical behavioral therapy, our DBT group, the trauma group, the group radical openness, which we would have done a webinar about a few months back. And then for some, that's treatment completed for them for the time, and they don't feel the need to go on and seek more mental health supports at that time.
Yeah, and just in terms of, I suppose, the referral pathway for our formulation groups, so patients must be under the care of a consultant in St. Patrick's to be referred to our group. And then the pathway of referral is that they must be assessed and referred by their team psychologist. So myself and Violet are the team psychologists on our geodiagnosis teams and our addiction team, but sometimes we might get referrals from other teams as well, because they might have patients on their team who have struggled with addiction as well. And then once that referral comes into us, we kind of have a further assessment. So either myself and Violet will meet with kind of prospective group members and try and get an understanding of whether the group would be helpful for them and kind of barriers that might come up and prevent them from engaging in the group. So in terms of evidence, I suppose group formulation and group formulation in addiction is a novel intervention that we have developed here in St. Patrick's, and we have completed the preclinical phase, which involves kind of looking at current literature and current evidence. So again, because we're a novel group, that's still to be gathered, that evidence. We've moved into phase 1. So in line with the Medical Research Council's framework for the evaluation of complex interventions, we are currently in the modelling phase for the formulation group programme, which means kind of looking at, I suppose, what you know, kind of running the group and looking at what tends to change for people, what the outcomes are, and then trying to get a better understanding of the mechanisms behind what some of these changes might be for people. So we are lucky enough to have a doctoral student in clinical psychology in UCD at the moment, who is helping us out with that research piece, which is great. So the proposed research will involve pre and post qualitative interviews with group participants, just exploring how they understand and make sense of their difficulties through a psychological formulation lens. And then we'll do kind of post interviews with those clients and explore whether they are, I suppose, what the changes are or any developments in how they make sense of their experiences kind of after completing our program. So data collection is expected to begin in early 2022, so around now, and we're aiming for 20 participants, and the data will be analysed using thematic analysis and discourse analysis.
So just in conclusion, how can I help people who present to my clinic? So I suppose remembering those core components, the importance of instilling hope, that kind of non-judgmental approach, validation, that, you know, those core components of forming a trusting relationship, and remembering the role of trauma and shame, and that what people really need is connection. And, you know, obviously we know in your roles as GPs, you wouldn't be doing long-term therapy, but I think it's often, you're often the first kind of protocol, or where people might go first. And I think there's a huge amount of power in that, the way that it's initially addressed for people, and the importance of addressing psychological factors alongside the addiction. So again, that multimodal approach, and that little quote there from Gabor Mate: substance abuse or dependence is related to stress response in an attempt to self-soothe. So taking away the substance does not necessarily take away the need. Then we need to give patients other ways to soothe that are effective and that don't create unintended negative consequences. So just references there. And I think people will get a copy of this, so you can look into those if you'd like. And then if we have time for questions.
Hi, thank you both. That was really, really interesting and informative. And you've come in well under time, so we've time to take a couple of questions here. And we do have 2 or 3 that have come in. So the first one there, as you said, the Canadian-Hungarian researcher said 66% of people with addictions have experienced previous trauma. Can you explain why in a large family who experienced a similar upbringing and trauma, maybe only one child becomes an addict in adulthood?
Yeah, so that would be related a little bit to that point I was talking about, how there, you know, it's kind of complex and it's nuanced. So first of all, often we kind of think about, you know, if we grew up in the same family, then we would have had the same experience, but that's not at all true. Depending on your location in the family, depending on your gender in the family, you know, where you were born, the eldest child is going to have a very different experience from the youngest child. And also we're born with kind of natural temperaments. We're born with natural different sensitivities in terms of sensory sensitivity, emotional sensitivity, and we're going to have different experiences, different interactions with our parents, can really vary. If any of you here have siblings and you think about, you know, your experience and their experience, you'll surely kind of relate to this idea that, you know, your siblings didn't have the exact same experience with your parents, or the exact same experience in school. They don't have the exact same personality. And it's such a good question, because it comes up for people all the time, and it's one where people tend to have a lot of shame, particularly, say, if they are the one sibling that has the addiction and the others didn't, then they think, oh, well, I'm just a failure, or there's something just wrong with me. But it's so much more complex than that. You mightn't have got the same experiences, the same supports. You might have had more traumatic experiences. You might have been introduced to alcohol or substances a bit earlier. Your brain might have formed that neural pathway that's a way to end the suffering really, really quickly. So it's just very complex and nuanced, even if we have the same parents. What our experiences will be, what our genetics will be, you know, all of that. So hopefully that makes sense.
That makes sense, yeah. Do you recommend that GPs and medical centres should engage in trauma-informed practice and care training?
Yeah.
Yeah, I think absolutely.
Yes.
Universal nodding from myself and Violet there.
Yeah.
Absolutely.
That was an
Yeah.
easy one. Okay. And then in terms of, okay, this might be more difficult, considering the neurotoxic and cytotoxic effects of alcohol, as in alcohol dementia, acquired brain injuries, alcohol-related liver disease, cancers, and many more, is the vagus nerve spared the systemic damage of excessive alcohol use?
It's a really good question. I don't think that I know the answer. I haven't seen anything in the literature to kind of indicate that there's a direct relationship between vagus nerve damage and alcohol. I mean, I think that there's something about the more alcohol someone uses, the more likely they are to be in their fight or flight, or in that kind of shutdown place, so in their threat systems. I'm not sure that that's necessarily it not working well, though. And I don't know if you'd have anything to add, Aideen. You have.
Yeah, I wouldn't be sure of the exact answer to that at that particular level. But as you say, Violet, just a lot of research around, I suppose, when we're in addiction, I suppose we do tend to spend much more time in that kind of fight or flight and that shutdown system. But it's a good question. I'd like to know the answer to that myself. Must look that up.
Great. I think that there are tons of other comments in there, just thanking you for a really interesting presentation, and wishing you best of luck with the research. I think we can leave it there for this evening. Thank you both, and thank you to all of our attendees. We had 75 people attending this evening, so it's a great turnout. This presentation, this recording, will be shared with everyone by email in a couple of days' time, and we will also be sending on the CPD certs. If you could allow for up to 4 weeks for those to be sent to anyone attending this evening by email. And then lastly, then you are going to see a link on your screen when we end this webinar, just asking you to provide us with some feedback. We'd really welcome any feedback you could give us. If you could take 2 minutes to click on that link. And thank you very much. If you want to actually keep up to date with any events that we have planned over the next few months or for the course of the rest of the CPD webinar series, you can just visit the events section on our website, that's stpatricks.ie. And I hope you all enjoy the rest of your evening. Thanks very much.